Hello and welcome to TB Ed Talks, a series from TB Fighters where we sit down with experts from the world of TB, learn about the thing they are the expert in, and ask them a bunch of questions. My name is Tori. I will be your host tonight, and with me is our amazing first guest of 2026. I can't believe he agreed to come on this, actually. His TB resume is actually way too long and impressive for me to read out, but the short version is that he is a professor of global health and social medicine in the field of medical anthropology at Harvard Medical School, as well as director of Harvard Medical School's Center for Global Health Delivery. He's also an affiliate professor in the Department of Anthropology in the Faculty of Arts and Sciences and a physician in the Division of Global Health Equity at Boston's Brigham and Women's Hospital. He's the author of Blind Spot: How Neoliberalism Infiltrated Global Health and one of the founders of the Zero TB Initiative. He has also worked extensively with our friends at Partners in Health on the treatment of MDR-TB, among other things. And an admittedly biased former student told me he's one of the best professors that she has ever had. So we are really in for a treat tonight. So please join me in welcoming Dr. Salmaan Keshavjee.
Thanks, Tori. Thanks, everyone. It's such an honor and a pleasure to be here. So I know you've had a few other talks, and maybe some of this is going to be repetitive because you've kind of learned a little bit about TB, but I thought I'd go through today the search, treat, and prevent strategy to eliminate TB, because a lot of us talk about eliminating TB, and I think the question, of course, is it possible? And the answer to that, I'll just give you the punchline, which is yes, it's very possible, and I'll tell you how and why. Well, let's just start. So you guys know a lot about TB. About 10 million people are getting it every year. I'm not putting any of the latest stats because they're always around 10 million, 10.5, 10.2, and about 4,000 to 5,000 people die every single day from it. So, the question is, why is that happening when we've had a cure since the late 1940s, early 1950s? Now, the United States TB rate is pretty low. It's around now about 2.5 to 2.8 per 100,000. The global rate's about 120, and it drops at 1.5% per year. So it will take us 200 years to get to the same rate as the United States if we keep doing what we've been doing. And so the question is, we've had slow progress, and how do we actually speed that up? Now, before I jump into the search, treat, and prevent part, I just want to mention that TB is the quintessential biosocial disease. All of you have seen John's book, and you know all about that. But it used to kill 25% of the inhabitants of Europe, and similar numbers in Massachusetts and New York. And very early on, people realized that there was this interaction between the biological and the social. And very early on, people realized that it was linked to things like living conditions, like housing, like food. And there were actually studies that were done that showed, there was a social experiment that was done called the Papworth Village Settlement in England, where people being released from a TB sanatorium were given employment and food and medical care. And those people that were given those things, they saw a dramatic decrease in TB incidence amongst the children under 5 who were born in the settlement. So people knew that if you actually could fix some of the social things like employment, food, medical care, etc., you could actually have a huge effect on TB. And same thing, food, has been studied a lot. British prisoners of war compared to Russian prisoners of war in World War II had the Russians had a 13-fold increased incidence of TB compared to the British because they were getting so many less calories. So really, it was well understood that you needed to have these other pieces. And there have been so many studies over the years, like from Glasgow, in the early 20th century, looking at people with more volume in their houses or overcrowded houses had more TB. And you don't even have to look back to the early 20th century. I mean, of course, it's wonderful to know that we've known this for 100 years or more. But if you look at data from London from the 1980s, in some of the boroughs, TB was increasing there's a 12% increase for each percentage increase in the number of persons living in an overcrowded living condition. So that's kind of crazy, even in modern days in a Western country. In New York City, in the Bronx, children less than 5 years of age living in severely crowded areas were 5 times more likely to develop TB, and this is in the 1990s. So we know all of this. And so social interventions are really, really key. We also know that air quality, and I won't really go into it other than to say that long-term exposure to emissions to combustible fuel emissions is associated with TB. So you can imagine people living near highways or in places with lots of smog, in cities that are overcrowded, bad housing, and with really bad air quality are at risk of TB. So we've got all of that in the background. So to help get rid of TB, we have to do that. Now I'm going to talk about the other piece, which is that we know that that's in the background and that's something that we have to work on. And then there's also kind of the medical strategy to get rid of TB. And I'm going to spend the rest of the time talking about that. So is it possible to achieve TB elimination? And the answer is yes. And we know it's possible because in North America and in Europe and in Australia and in New Zealand, basically in rich countries, there has been an approach that has been used since the early 1960s, which we now refer to as the Search, Treat, Prevent Comprehensive Epidemic Control Strategy, that has been used to stop TB. So let me go a little bit into what that's all about so that you can get an idea of what needs to be done. So here's a kind of a pictorial, a picture of what I'm going to talk about. And you'll notice something, and that is that the search, treat, and prevent are in a circle, and they're kind of interlinked. And I hope that as we're going through the different parts of search, treat, and prevent, you realize that they actually kind of have to happen simultaneously. It's not like a stepwise thing, like let's search for people and then treat and then prevent. And you obviously have to do something in a certain order because you have to find the patients and find their families, but you can't just say, well, we're going to focus on search this year and we're going to focus on treat next year and prevent the year after. It's kind of has to be done all the time because you're turning off the tap. And I'll show you a little bit more about that, but you're turning off all the sources of TB in order to stop transmission because it's an airborne disease. So you can't just have a little bit of transmission because if you have a little bit of transmission, it's transmitting in the air and it will go to, from person to person. So very, very early on, people realized that if you found somebody with TB and you treated them, you usually found somebody else later on who wasn't sick in their families. And the reason is that less than half the people who have TB have symptoms. Sometimes, it may be 40 or 60% have 40 to 60% who have symptoms, but you'd be in communities where some people look really healthy and they, you're like, oh, they couldn't possibly have TB. And then you do a test to test them for TB and it comes out positive. And so very early on, people realized that you had to have some test that was very sensitive for, changes in your lung to help you identify TB. And very early on, the other thing that was discovered was that if you found cases early, it led to lower mortality and less transmission, which makes sense, right? Like if you find that somebody's sick and you send them for some curative activity, they're going to have less transmission. So let me go a little bit into that. So the X-ray was created at the turn of the 19th to the 20th century, and this is a picture of Sir Robert Phillip. He was a doctor in Edinburgh in Scotland, and he basically realized that as they were screening people who were sick with TB with an X-ray, they could find that they had lesions that they knew was TB, but then they realized that, well, the family members seemed to be getting it. So they started screening family members with X-rays, and they found people with very early TB. So that was pretty amazing. And remember, there's no medicines at this time. So what they're doing is they're sending people to a sanatorium where you have clean air, isn't that interesting? Where you have high volume of space in the rooms, also interesting because we have these data from Scotland, and they give them food and sleep. So basically, they're reducing the risk that, if you were infected, you'll go on to have disease, or if you have disease, you'll go on to have bad disease by doing this. So people who were sick or people who, had started becoming sick, or if they saw even a small lesion on X-ray, they would send them. And what they found out was that they found the new cases, but by doing this, they had less deaths. So this became one of the hallmarks of early TB control, which was going and finding people using X-rays. And here's an example from the United States of people like standing in their clothes and just going and standing in front of an X-ray machine, and you could be screened. Here's another one. And so that was really, really amazing. So the idea was that you had to have a test that worked. And the X-ray is very sensitive for TB, but not specific. but that you could basically see the lesions and you could treat people. Now we have other tests, which I'll mention in a bit, that are actually more specific for TB. So you can do an X-ray to screen, and then you can do another test to confirm it's TB. So that was the first big thing, is finding people, getting them sent off for treatment at a sanatorium, and that reduced mortality, and that was incredible. And then treatment appeared, and people realized that, and I'll go through how they realized this, that early treatment with the correct medicines given over a short period of time helped stop transmission. So, the first drug was actually only isolated in 1943. Here's the picture of two of the people who isolated it: Salmaan Waxman and Albert Schatz, one of the graduate students working with him. They helped isolate this drug, streptomycin, from soil. They sent it to colleagues at Merck, one of the drug companies, and it was purified, and they gave it to the first human TB patient in November 1944, and she was cured. So this was mind-blowing. Here's a disease that was killing 25% of the population, right? Just about 50 years before, and they found a drug that could cure it. And it wasn't only that drug. In 1948, there was other drugs. There was a drug whose name is hard to pronounce, para-aminosalicylic acid, but it's known as PAS, which is easier to say, and a bunch of other drugs, thiacetazone, another drug, isonicotinic hydrazide, which became the backbone of TB treatment. Easier name is INH, and a few other drugs were developed. And people realized, wow, there are all these drugs that can help kill the TB bacteria. And after it was given to this first human, the British Medical Research Council, BMRC, the British Medical Research Council did a trial to see how, it was one of the first clinical trials. They wanted to see how well this drug worked. And they gave it to 100 patients with TB. And guess what? They found out they gave it to 100 patients, and some people got cured, but some people actually had their TB return. So they had a relapse. And when they looked at the strains that relapsed, they found out that they were resistant to streptomycin, the drug they were giving. But if they gave streptomycin with PAS, the other drug, guess what? There was less relapse and less resistance. And then when isoniazid was developed, INH, they used it alone, and guess what? People relapsed. And when they gave it with streptomycin or streptomycin and PAS, no relapse. So and then there was another drug later on, rifampicin, which is a really, really good drug for TB. And same thing, when it was used, you got relapse. If you used it in combination, you didn't get relapse. And so they realized that you got drug resistance if you used a single drug, streptomycin being the first. And then they started doing, like in 1955, just a few years after these drugs were used, they did a drug resistance survey in the UK, and they realized that resistant strains actually were being transmitted. So people thought, well, if you got drug resistance, maybe, they won't really get transmitted and you won't get sick. And so they realized that the strains got transmitted. And so multi-drug resistant regimens were needed. So that was amazing. So first, you use an X-ray to find the people. Secondly, you treat them with multi-drug regimens so that they don't get resistance. Great piece of information. And here's the data from the drug resistance survey. They saw resistance to streptomycin, to PAS, to INH, and they realized that these strains could be transmitted in the community. And so that means the bugs were actually, transmittable. And then they also found that it was usually resistant to 1 to 2 drugs. So if you gave this multi-drug regimen, you could solve it. So very useful pieces of information. Then the next thing is there was a series of experiments, and this is kind of interesting. Guinea pigs are animals that are very sensitive to TB, and they took basically the air from a patient's room, and they put it into a chamber of guinea pigs. And they took the air from a patient's room where the patient wasn't treated, and they put it into the guinea pig chamber. And if the patient was untreated, 100% of the guinea pigs got infected. Right? So that tells you it's passed in the air, and you're going to get infected if you breathe in that air. But then they put patients on treatment for as little as 24 hours. So not enough to cure TB, but they gave medicines for as little as 24 hours, and only 2% of the guinea pigs got infected if the patient was treated for 24 to 48 hours. So that told us something really interesting. It didn't kill all the TB in the lungs, but it reduced its infectivity. And so what that taught us is that it was really important to get people on the right treatment as quickly as possible to stop transmission. So not putzing around, not waiting, making sure you're getting them on the right treatment. And if they had somebody with drug-resistant disease and they put them on regular TB treatment, the guinea pigs got infected. If they put them on the right treatment, almost no guinea pigs got infected. And these experiments have been redone recently, by the way. Okay, and there were studies from China later on, much later in the early 2000s that showed the same thing. That if you waited, more people in the household got infected. Same thing with the USA, in the US. And if you got people treated early, less people got infected. So it was very convincing that you got to get people on treatment super quickly. Okay. And then they found out something really interesting. In the olden days, everyone had to go to a hospital for treatment. And there was a study in Madras in India. It was a 5-year study. And they basically saw that when people were treated at home, there was less relapse. And that there was no greater infection of contacts. People were like, oh, we can't treat people at home because, they'll infect their families. But it turns out their families have also been exposed to TB. So you don't infect more or less. It was the same, whether they were treated in the hospital. So you actually got slightly better outcomes by treating people at home. So that's how we got home-based TB therapy. So another important tidbit. Okay. So we learned early treatment with correct medicine stops transmission of both drug-resistant and drug-sensitive strains, and you can treat people at home. Great foundational thing. Now we get to the next thing, where people learned that preventive therapy, like preventing TB infection from becoming active disease by delivering preventive therapy, was really important. And how did that happen? Well, the US Public Health Service was working in Alaska because Alaska had one of the highest rates of TB. The prevalence, the amount of TB in the population, was 2,000 per 100,000, 2%. And 1 in 4 infants in some areas became infected in their first year of life. So visualize 25% of infants were getting infected in their household, probably from their parents or close community. And the mortality from TB was 282 per 100,000. Now, let me put that into perspective. The TB rate in the US right now is about 2.5 per 100,000. This was the mortality in Alaska was 282. So the US Public Health Service, led by a colleague, George Comstock, started an ambulatory treatment program, outpatient treatment, to treat active cases. They were x-raying everybody. They were looking for cases. And, they were just like, wow, we can really solve TB. But just like what Phillips saw, once you found cases and you treated them, very similar to what was seen in Edinburgh many years before, people in the household, after being screened with an x-ray, suddenly got TB. And so people realized that TB had different states. And one of the ideas was that, well, there was this latent TB that kind of just sat there. They called it latent. Turns out it's not really latent. So we now call it TB infection. But they thought, well, why don't we, maybe we need to treat this TB, this latent TB. And so they began a randomized control trial in 1957 to evaluate the use of isoniazid, INH, prophylaxis. And they took communities and they divided them up and they randomized them to receive either isoniazid or placebo. And they found something really interesting. So they did that. And then they looked at kids. Remember I told you a quarter of kids got infected in their first year of life? So they asked the question, how are we going to know if transmission is being reduced? And they said, well, right now we know a quarter of kids are being infected. And if we give this isoniazid therapy to the community, will we see the number of kids being infected drop? Because they're doing active case finding, they're doing treatment of all forms of disease, and they are now doing this other intervention, treatment of TB infection. And what did they see? Lo and behold, they see this drop of infection amongst the kids living in the household. That tells you that the parents and family and grandparents and people that they're playing with, remember, these are kids under 3. They're not at a bar. They're not at cafes. They're not even at school. They're just at the household. So this tells you community transmission was going down in the places that they were getting isoniazid prophylaxis. And sure enough, they found that the rates of TB in the intervention group had dropped by close to 70%. And people said, oh yeah, but they're going to get infected again next year or the year after. Well, Comstock followed them for almost 20 years. And guess what? Those who received isoniazid prophylaxis had a reduced risk of TB over the next 20 years. And a really interesting tidbit, they not only had reduced TB and reduced mortality from TB, they had reduced all-cause mortality. So that tells you that the TB was kind of maybe hijacking or manipulating the immune system. They weren't dying from other things because their TB was cured. And then there were tons of other studies done to show this. There were 11 studies showing this in non-infected people, and another 12 in HIV-infected people that showed that you needed to do this, and saw similar drops in TB. So there was this old idea, which is what they were basing this on, that there's latent infection, it's asymptomatic, it's not contagious, but then they realized it can turn on, something turns it on, right? So they gave isoniazid prophylaxis. Now there's new understanding about this. We don't think of this as latent. We think there's a spectrum between infection and disease, and it's kind of based on how good your immune system is. Remember how we saw that if you have food, you don't get as much disease? Well, it could be that food affects the immune system. And we now know that even like when somebody's infected, you can sometimes isolate small amounts of TB from them, and it's metabolically active. And so now we think of infected and disease as a spectrum, and that mycobacteria are released. So some people are like, well, I'm just going to treat disease for now, and I'll leave infection till later. No, you can't do that, because if you leave infection till later, you basically there's small amounts of mycobacteria that are being released. And people who are infected, some of them can go on to have disease. So at first, when people were talking about this, they said, oh, but if you give people isoniazid and, you're going to cause more drug resistance, by using isoniazid prophylactic therapy, INH prophylactic therapy, you're going to basically cause a problem, and there'll be more drug resistance. 13 studies were done showing that that wasn't the case. If you x-rayed people and you saw that they didn't have TB and you gave them preventive therapy because they were exposed to it, they basically reduced the risk of TB, and there was no drug resistance. And so if you think about it, we used to look for TB under the microscope, in the late 19th century, and until recently in poor countries. And that was a small amount of the TB you see. And then there's the TB you can see using an X-ray. And there's some TB I'm not going to really talk about today that people get that goes into the rest of their body, their bones, their intestines, their uterus. And then there's TB infection, which a lot of people have. And then there's the 8 to 10% of contacts who get, who within the first 2 years will go on to have active disease. That's who you have to give preventive therapy. So people were like, oh, are you going to treat all the people with TB infection in the world? And the answer is no. You're just going to treat the contacts of the 10 million people who have TB every year. So that if there's 1 to 2 or 3 contacts, you've got 20 to 30 million contacts a year who should receive treatment. So you're treating 10 million, you should be, and then you just treat their contacts at the same time as you're giving the other therapy, and you can solve it. So there's an epidemiologic reason, right? So there's an 8 to 10% lifetime risk. There's the transmission reason, because if you find the people with early disease and you treat them, but you don't turn off the tap on the 10% that are turning on, you're going to have a problem. And then there's a moral reason, because you guys have seen that people who get TB have all sorts of lung problems, their kids get it, people die for no reason. It just causes illness. And we now know it reduces all-cause mortality. So there's a medical moral reason to do this. And so in Alaska, you saw this drop in the household. And here's data from Rio de Janeiro, which wasn't the US Public Health Service in a closed system working in the whole community, but this happened in a very poor part of Rio. And the bottom bar there that you see is basically people who got TB preventive treatment, they had lower rates of TB. So even in some of the toughest areas on earth, it works to reduce rates. And the WHO modeled this years ago, never actually advised it for poor countries for a long time until 2018. But they showed that if you just treat active disease, you kind of get a plateau. And if you treat active disease and so-called latent disease, TB infection, you get a much steeper drop. And we see this around the world. This is Peru. The rates of TB kind of just plateau. And they plateau at around 100 to 150, right, per 100,000. That's it, because they're not doing preventive therapy. Thailand has got a great TB program. They plateau at around 170, and it just stays where it is, right? And this is all the USAID funded countries between 2010 and 2017. And there's some bars that look like they're going down, but a lot of them are almost straight lines. These are the 22 USAID TB countries. And that's because they're just doing mostly treatment and no prevention. Those are our dollars, by the way. Our dollars are going to this.
Yes.
Mind-blowing, right?
Right, of course. And I have to ask the question that you're probably about to answer, but why would the WHO not recommend the prevention?
I was not going to answer that, but I will now that you asked it, which is that they thought that it was too expensive and that it would be confusing for poor countries and take away their focus from treating active disease. And it was, I think, a strategic mistake. Like, I think it was well-meaning to say, okay, let's focus on the sickest people, but it was a strategic mistake because it never turned off the tap. Now, you could say, well, if they didn't do that, these bars would be going up. These lines would be going up. That's probably true. But so lives were saved, but TB elimination wasn't achieved, and you had the same amount of people dying every year, essentially. And so, that was the downside.
Right. So the predictable reason.
Predictable reason, yeah. Yeah, basically, really just low aspirations for people who come from poor countries, and this idea that you could have this divergence of treatment where in rich countries you'd use search, treat, and prevent, you bring down the rates, but you're kind of like, well, poor countries aren't ready for this yet, except that this is airborne and it circulates around the world. So treating TB infection is an essential part of stopping transmission. So here we have it, the basic principles: search, treat, give the correct treatment, and then give food supports, of course, and prevention. And I haven't mentioned infection control just for time reasons, but you can imagine you need to have proper infection control because it's airborne. So you need ventilation in health facilities, etc. Okay, so here we are. There's somebody has no TB infection, you get exposed to TB, you get infected. But if you get preventive therapy, you don't get disease. If you get TB disease, you need treatment. If you don't get treatment, you die. So we're basically have to turn this off at every point in this pathway to prevent death and suffering, and of course, many other things that come from TB. Okay, so what can be achieved if you do it right? Well, this is what happened in Alaska. It dropped. The prevalence was 2,000. The prevalence was 2,000. The incidence, which is the amount every year, was 500 per 100,000, and it just dropped. You can see it here pictorially. And New York City had an outbreak in the 1980s that was linked to homelessness and high HIV and other things. What did they do? They did search, treat, prevent, and you see it dropped. In Russia, where Partners in Health was working, you can see starting in around 2000. So we started working there in 2000. And in 2007, the rates started dropping. And we asked the Russians, what are you doing that we are not doing? Because why is it suddenly dropped? And they said, oh, we've started x-raying people in the community to screen, and we've started doing preventive therapy. Bang, TB rates dropped 55%. We took this to another province. TB rates dropped from 69 to 10. This is in Russia. Really hard living conditions. This is Singapore. They dropped, and you see that they plateau. That's because they were just doing treatment of active cases. They included preventive therapy. They dropped more. This is Taiwan. They dropped, you see how it's dropping. And I said to the Taiwanese, why do you have this drop and China doesn't? And they said, oh, because we're not a member of the WHO. Because, China doesn't let them become a part of the WHO. So they followed US CDC guidelines, same things we were following. So basically, we just realized at some point that we got to recreate that system and use search, treat, and prevent everywhere. And we have the tools. Now we've got mobile x-ray machines, we've got AI. You can see this is it, the one on the complete right. The two on the left are in Pakistan. The one on the right is in Nigeria. It's just being done with a portable x-ray that looks like a portable camera. We've got of course laboratory equipment, but if you look at the two bottom slides on the right, you've got something that looks like a Nespresso machine. You just put sputum into it and stick it in there, and it tells you what the strain is and whether it's TB. And the next one is from India. It's called a TrueNat machine, and you can just do that almost anywhere. And Pakistan tried this. They got money from the Global Fund and a group called the IRD, Interactive Research and Development Global. They did this work. They got 55 of these vans, just like the early 20th century, except they used advanced digital x-rays that could tell you if somebody was sick or not. And they worked in this area called Korangi. That's the red line. And the rest of Karachi is the blue line. So you can imagine if you start looking for people, you find more than the baseline, which is they did. You see a peak, and then it started going down. And they had a 30% decrease in TB. I told you the rest of the world drops around 1 to 1.5%. So that's a huge deal. So search, treat, and prevent in Karachi looked like this. I presented as a little circle, and it is, but there's a lot of pieces to the circle. And it's programmatically complex, but entirely possible. And I'm going to go back to that slide. They brought it down 30%. And then the program stopped for various reasons, but this was pretty incredible. And again, you're going to see a peak because you're going to find all of these cases and you're going to see a drop. So that's really that's really the story of Search, Treat, Prevent. We've started doing it in Lima at PIH sites with Halt TB. This is it in Lima. They thought the rate where we'd been working in Caraballo for 25 years was about 75 or 80 per 100,000. When we started bringing out the x-rays and screening people, it was above 500 per 100,000. So all these people that had TB but weren't found. Here's Lima. This is Bangkok. They've started doing this in Thailand. They bought vans and they've been doing this in the country. This is Cali, Colombia. The PIH Peru team had helped the Cali people and they're doing screening. On the left side is at the border with Mexico and Mexicali with using a portable x-ray. And I showed you the one from Nigeria. So, search, treat, and prevent, it's got to be comprehensive and it's got to be simultaneous, or else the tap is open and you're spreading it in the air. So it's got to be all of that. And I just want to end by saying one last point. A lot of people say, well, TB is not the only killer in the world. Why are we spending so much money on it? Should we be doing other things? It is a killer. It's the biggest infectious disease killer of adults. But this delivery platform of going into the community where people live and work and screening for disease and treating them is actually a platform for a lot of other diseases. Heart disease, hypertension, diabetes, hepatitis C, HIV, even mental health disorders, autism, cancer care. Breast cancer is is not identified, and early breast cancer is curable. Early lung cancer is curable. So this whole platform of going in and screening people in the community where people live and work and then getting them on care is a model. So TB for me, and I think for all of us, is just a start for this whole thing. And here, here's a family van in Boston. And they're not screening for TB, but they're screening for childhood diseases and stuff. And I asked the woman who runs this, I said, who comes to this? And they said all sorts of mothers who are working in the daytime. They bring their kids in the evening and get treatment. So we really have this incredible model. And so to go back to the question, how do we achieve the goal of TB elimination? Search, treat, and prevent, which is basically creating a system to diagnose and treat people in the communities where they live and work for TB, and hopefully so many other diseases. Thank you.
Oh, thank you. And I have a million questions, and we have a bunch coming in from our chat too. But I will say that the people who said that you are a great lecturer were definitely right.
Sorry, I went a bit over time.
That we're not going to complain, and also you are welcome back anytime. So we have a bunch of questions. Some of them were pre-submitted, and some of them are ones that have come in, and some of them are mine. But one of the first ones, selfishly, it's mine, and I'm going to ask it. But I would love to hear a little bit about what the hypotheses are about the connection between what would happen with multi-drug resistant TB and drug resistance generally if Search, Treat, Prevent was widely adopted.
Oh, so I didn't present this in the slides, but there's actually studies that show that a large percentage of MDR strains come from TB infection caused by MDR-TB.
Right.
So I'll tell you something interesting. We at Partners in Health, working in partnership with our colleagues in Russia, we did another study where we treated contacts of regular TB with preventive therapy for regular TB, people who had MDR-TB, had preventive therapy for MDR-TB. We used what New York used, which was a drug called moxifloxacin, and gave it for a certain number of months. And we gave that, our Russian colleagues gave it, but we helped them develop the idea. So they gave moxifloxacin for MDR-TB, and then XDR-TB, which is strains of MDR-TB that are super resistant. We gave a drug to which it was susceptible called bedaquiline. It was one of the new TB drugs. So we gave treatment for prophylaxis for regular TB, MDR-TB, and XDR-TB. It was a small observation study, so our role was to look at analyze the findings that our Russian colleagues had, and you will never believe it. I was actually stunned at how well it worked. 0% of people who got preventive therapy for regular TB, MDR-TB, and XDR-TB went on to get TB.
It
And
is shocking.
5% of the people that didn't get preventive therapy for whatever reason, they were sick, they refused, whatever the reason was, they got MDR-TB or XDR-TB or regular TB. So it was 0 versus 5%. And now it's a small sample. I'm not going to say this is the be all and end all, but it basically showed us that you could prevent all forms of TB using preventive therapy. And colleagues in Pakistan also did that in a community-wide delivery, and they saw similar things for MDR-TB. So you're asking what would happen to MDR-TB if we did this across the board for all forms of TB? I think we would drive down rates across the board. That's what would happen.
Yeah, and that makes perfect sense and seems like the very logical thing to do, especially as I was in a presentation the other day where we were talking about bedaquiline resistance, which just terrifying. So, it seems like such a logical approach. On a similar theme, we had another question from Mina in the chat about how is it that giving therapy with isoniazid didn't increase resistance to isoniazid? Is it, sorry, I got to read this. Is it not true that more of a certain antibiotic is used, the more susceptible it is to resistance?
It is true. So there's two ways that you get resistance, right? One of the ways is there's kind of like every bug just kind of naturally through mutation, you can create resistance, and that's not something we can control. And the other is, of course, using an antibiotic. And if you use an antibiotic, a certain population of a given bacteria will spontaneously develop resistance, and then those resistant strains will grow. Now, what's interesting about preventive therapy for TB is that if the person truly doesn't have active disease, if they truly have this very quiescent form of TB, where they're just infected and it's not really doing much, it's metabolically active, but just a little bit. It turns out that if you give preventive therapy to that person, you don't get drug resistance. And as I told you, there's been 13 trials looking at that. So, but now the key is you got to make sure they don't have TB. So you can't be giving it willy-nilly. You have to. So what we tend to do is we x-ray the person and you don't see any lesions. Some places, like in Russia, we also took a sputum and tested it with Gene Expert, and it came out negative. And then we gave that group preventive therapy. So, I think one has to be rigorous about ensuring that somebody doesn't have TB before you give the preventive therapy. One solution is, and this has happened in many countries, is that you give 2 drugs as preventive therapy. So, you still screen people. You should never give it without screening people. You screen them, but some people say, well, we feel uncomfortable giving a single drug. We should give 2 drugs. And so people used to give isoniazid plus rifampin for 4 months or 3 months. And that could, that would allay the risk of possible drug resistance. But again, the studies have not shown that there's drug resistance if you screen people properly.
Okay, that's very interesting. So we have another question here, which is from JJ, because the circle that you showed about the search to prevent, there was a very strong reaction of everybody really liked it. It was a very good explanation. And so with the thought of that needing to be simultaneous, is that the same for addressing food and housing and air quality along with the medical approach, or did those other contributing factors need to be addressed in a specific order?
I think they also need to be addressed. So let me just say something about this, the circle. We haven't been calling it this lately, but we used to call it the treatment chakra. I know that sounds very new agey, but the whole idea that it has to be the circle, right? It's kind of like a circle of life for the patient, but it's also the circle of transmission that you want to block. I forgot the second part of the question.
Do the other contributing factors, food, housing, air quality, et cetera, need to be addressed?
I have to say, in general, the TB community has not focused on that. At Partners in Health, we have, in Haiti, we have, when TB patients were being treated, housing, food, et cetera, was given. In Peru, we used to actually, when we first started the MDR treatment program, also food, housing, even job training. So very much in keeping with that data, the international community has pushed towards giving food as what they called enablers or incentives, but really not a focus on housing and other things. And so what's happened is that those things have fallen off, have fallen by the wayside. And now, a lot of countries, including India, for example, are giving money to patients. They're giving conditional cash transfer to patients who are on TB treatment. They'll give them a certain amount per month. It's not very much in the case of India, but it's something. So I think there's increasingly a recognition that throwing a bunch of drugs at people can work, but it's much better if you give, you allay some of the problems that are caused by poverty.
Mhm.
And there are so much data from the United States, from other colleagues who are looking at food, that food is such a strong predictor of whether you're gonna progress from infection to disease, that maybe we should just be giving everybody food. Now, at Partners in Health, we've done that, and I
Mhm.
think that's why we often get good results in our programs. But I think that that's something that needs to be done more. So I think that's one of our gaps. Now, why have we not pushed it, and why is it not in part of the chakra? Because it should be part of the prevent chakra,
Mhm.
right?
Right.
And the reason is because the people to whom we were urging to use the chakra, they basically view, like in many countries, if you went to a donor and you're like, we want to give the patients food and housing, they're like, what? They don't, they want to like, to give treatment. And and of course you could say, well, if somebody's starving and starvation is the cause of this disease, the treatment for starvation is food. And if this is an airborne disease and house volume and overcrowding is part of the disease, then therefore we want to actually have less, so it's actually a medical intervention, but a lot of donors don't want to fund it. And so we made a strategic choice when we were doing this, and maybe it was a mistake to not, very directly say that the prevent is not only preventive therapy, not only doing infection control, but also making sure that people have food and housing.
Right.
Instead, what we did is part of the treatment, we said, well, people have to take a lot of pills, they can't do it on an empty stomach, etc. So you have to give it as a treatment enabler, you have to give some food to people. But I think that was a strategic choice in kind of selling the idea globally. And maybe, we have to revisit that, because I think it's really important to be thinking about the other social dimensions.
Right. And the phrase disease of injustice is just one that I hate has
Yeah.
to exist. But the thing that always comes to mind is the treating TB without food is washing your hands and wiping them in the dirt, right? Like it's
Yeah.
all part of the same problem, which is one we hear a lot.
And the housing, and there's things like, so the data coming out of China are showing incontrovertible, like like the air pollution is a major problem. And so when you start to think about the world we've created, and we're burning fossil fuels, people are burning fossil fuels in their houses. I mean, we are too if you have a gas stove, but in general, people are burning all sorts of fossil fuels in their houses, and these are communities that are at high risk of TB. Like, there's so many things that you could think of. Like, should we be doing solar energy and giving people alternate energy sources to cook? There's lots of things that one could think of to make people's lives better. And TB is not the only lung disease you get from burning fuels in your house. So there's a lot to be thinking about, for health.
Yeah, and that actually brings us to one of our other questions from Connor, which was regarding air quality. Does this mean that more frequent wildfires due to climate change will probably have an impact on TB rates in places affected by
Well,
the snow?
so the 10 micron air particles that come from burning these things do have an effect. We know that. So like, if you're thinking of, of course we have low TB here. So
Mhm.
the wildfires that we're having here in North America, of course, affect health
Mhm.
negatively, but probably not so much with TB, except in high risk communities, of which we have some, which
Mhm.
are, people who are undernourished, people are living on native reservations and things. They are at high risk, and wildfires probably add to that. But in other parts of the world, you have these huge wildfires burning in, Indonesia and other places, and you see these clouds of smoke going across parts of Asia. I think they are contributing to TB,
Mhm.
undoubtedly, and the data would suggest that they are. And so, and fossil fuel burning, which the biggest source is not a wildfire, it's cars. So
Mhm.
the move to electric cars, the move to emission-free energy. What's emission-free energy? The most notable form of emission-free energy that can happen at scale is nuclear energy, but also wind, also solar, right? So, as the world moves towards that, I think hopefully we will see that, this plays less of a role. Cigarettes. If you smoke cigarettes, you have, like, I think it's a 20 to 25-fold risk of getting TB. If you work in a mine and you've got silica dust and all this stuff, you have like a 15 to 20, 25-fold risk of having TB. I can't remember the exact numbers, but it's around that range. It's very big. So, all this stuff that kind of agitates your lungs, causes hyperinflammation, it just doesn't help you with diseases of TB and a number of other lung diseases as
Yeah.
well.
Yeah. Yeah. So yeah, there's just so many things that fixing them could help, and helping a little bit seems like it will, go a long way. One of our pre-submitted questions is actually from John Green, and he asked me to ask you what you can tell us about the ongoing project in the Philippines.
Well, it's really an exciting project because I showed you that USAID graphic where
Mhm.
the lines were essentially flat. And the Philippines is a really interesting country. For some reason, uh, there's various historical reasons about access to antibiotics and other things, but for some reason, the TB rate in the Philippines is roughly somewhere between 500 and 1,000 per 100,000. So that means up to 1% of the population is infected with TB. That's scary. 1 in 100 people, right? So the question is, how do you bring down the rates? And John, in discussion with the director of USAID at the time, Atul Gawande, they were having a talk, and John said, why don't you choose some cities to make zero TB cities, and maybe we can work together. And so it turned out that USAID chose the Philippines and Ethiopia as sites where they would have these zero. It wasn't cities, but regions, and John supported PIH to help the work in the Philippines. And so what we're doing there is we're working on an island called Guimaras, which is in the Western Visayas in the Philippines. It's one of the regions. And this island has a TB rate of somewhere around 600 to 1,000 per 100,000. And I'll tell you, recent data suggests that it may even be higher than that, when we're screening people. And we've spent a lot of time trying to work with the government to implement search, treat, and prevent, and they are. They've made this into a special zone where they're going to implement, they're using x-rays to screen people. They're giving treatment for drug resistant and drug sensitive disease, and now are doing preventive therapy for drug sensitive disease. And I mentioned to you that the WHO didn't encourage preventive therapy. They changed that on March 4th, 2018. And this is US policy since 1962.
Yeah.
Almost 60 years later, they changed it. And here we are at 2026, and the government of the Philippines, it takes time. They're moving away from the WHO guidelines that said not to treat it, and now towards a more comprehensive approach. And Guimaras is one of the first places where that's being tested and implemented. So it's really a chance to see if search, treat, and prevent can work on this island. And it's going to be a model, I think, for the rest of the Philippines, which desperately needs to bring down rates. And I think it's going to be a model for a number of other countries in Asia that are trying to do this. So, I think, I can speak personally. I'm so grateful to John for kind of spearheading and making sure that this can happen, but also to the people, the government of the Philippines for saying this is worthwhile doing it. And now that USAID isn't there anymore, the government of the Philippines is essentially putting in their own money to make this happen in this one place. And so, we've been working really hard to make it happen. And I have to tell you, it's moving well. We don't have any results that have shown that rates have dropped, but we now have found a lot of cases of TB. And again, we being our colleagues in the Philippines who are doing this, but the rates of TB are dropping, and a lot more people, like rates of people put on preventive therapy, have gone up multi-100%. And so that they're really moving towards this comprehensive approach. So let's see how it works out over the next 2 or 3 years.
Right. It's hard because these things sound so exciting, and then it's like, nope, we have to wait and see,
Yeah,
wait on the data. But
it's a long-term game, I think.
it is. I mean, TV has been playing a very long game over several thousand years, so we're catching up. Would you be able to talk a little bit about what implementation of a program like that at scale looks like? I know it's probably part of it is dealing with the governments and those stakeholders, but also about like the engagement with the community and patients more generally, and onboarding there.
Yeah, so it's really interesting. It's very easy to say search, treat, prevent, let's do it, etc. But there's all these policies in place, and usually, governments have all these rules and regulations and laws that have been developed over years, right? And so that's why when I tell you the WHO changed their policy in 2018, and here we are in 2026, and we're just, guidelines are being changed bit by bit. You're like, what? It's taken 8 years? But yeah, because it's not like you just walk in and be like, hey, there's a new guideline, let's just do it. That happens in some places where you have very responsive systems, like say the United States. We
Mhm.
do that with cardiac disease, etc. But in lots of parts of the world, the WHO policy changes, then the country starts changing their policy, then they implement it bit by bit. So we have found that that is one of the barriers to moving very quickly, is old policies that are kind of blocking it. And then there's also like the nuts and bolts of the operation. So if I tell you, guess what? We're not just going to treat the patient now, we're going to treat all their relatives or the people that live in their household. So your next question is, well, so I have to screen everyone. I can't just give preventive therapy to them. I got to screen them to make sure they don't have TB, right? So let's say I found the index case, the person with TB, by doing a community-based screening with an X-ray machine. Now I've got to go to their house where 5 people live and convince those 5 people to get an X-ray.
Mhm.
So either I can take the X-ray machine to their house, or I have some other test. If there's some magical test, there's a new swab test coming
Mhm.
out that may change the game. So maybe I got to figure out if they have TB. Then if they don't, I got to convince healthy people to take preventive therapy.
Mhm.
And a lot of them are like, "What? You want me to take 3 months of medicine once a week? Really? No, I'm
Terrible
fine.
experience.
Yeah, I don't need that. I'm healthy." You got to convince. So that's one piece. And how much staffing do you need to do that?
Yeah.
How much extra medicine do you need if you're going to do that?
Mhm.
Who pays for it? So suddenly your costs go up. Now, of course, we know that you're going to see a drop later, so your costs will go down, but ultimately your costs go up. So
Yeah.
the government's like, what? We need to buy, we thought our TB rate was 75 per 100,000. You've now found 500 per 100,000. We have to buy more medicines. We have to buy 5 times more medicine. And
Yeah.
now you're telling us we have to treat these relatives who aren't even sick. Shouldn't we focus on the sick
Mhm.
people? And
Yeah.
so you can imagine that there's like the financial aspect, there's the policy sphere, and then there's the actual operations. How many people do you need to deliver this care? How do you monitor the people? How do you make sure they took it? Do you set up an SMS system? Do you set up reminders? Do you do it under observed therapy? So basically, what you're doing in each of these areas, like what we're doing in Guimaras right now, and PIH is doing in Lesotho and other places, is you're basically saying, okay, let's run a phase one of this and see what are the excess drug needs, what are the excess costs that will be, you'll need to get money for, what are the staffing needs to do this,
Mhm.
right? So there's lots of operational things that you need to change the way a health system is working in order to implement something. So, and then the other part of it is political will, like the government needs to want to do it. And
Right.
it takes a lot of time to convince people to want to do it. So the Philippines is at the stage where they agree to do it. They've now been convinced that it needs to be done. They believe in search, treat, and prevent. And now in the island of Guimaras, they're screening people and they're
Mhm.
seeing, okay, how many more are we finding? What are the drug needs? And how do we convince this other group of healthy people to take preventive therapy?
Mhm.
Now, you may ask, well, is it worth it? Well, yeah, it is worth it because you know what? The number one killer of people in the world, non-infectious, is heart disease, and it's often caused by hypertension that causes strokes, right, and heart
Mhm.
attacks. And guess what? 60 to 70% of the people don't know they've got hypertension. And if
Yeah.
you don't know you got something, you don't go to your doctor and ask if I have it.
Right.
You need to be screened.
Yeah.
And people with hepatitis C, 1 in 50 people in the world has hepatitis C. 40% of them are going to die of liver cancer and or cirrhosis of the liver. But guess what? More than half the people don't know they have it.
Of course.
Same thing with diabetes, right? So we're doing this for TB because TB is the biggest infectious killer of adults, but a lot of diseases require community-based screening and then treatment of people who don't know they're sick yet, and feel just fine.
Right.
So
And
that
the second and third order consequences of doing it are only positive, right? You're going to just
100%. So in the
help
Philippines, what
everybody.
we're working with the Filipino government to do is they're saying, okay, we're going to be in the community.
Mhm.
Here are our 8 problems. And one of the problems is hypertension. One of the problems is diabetes. One of the problems is infant mortality. Most babies die of,
Right.
of, of, of pneumonia or diarrhea. Fixable for 5 cents a tablet. Fixable, right? So you're just like, oh, wow. So if we're screening in the community, we can solve 2 or 3 or 4 of your big problems.
Right.
Because while you're waiting in line to get your TB X-ray, I can take your blood pressure.
Yeah.
I
At
can
some
take a
point, you're probably
drop
going to
of
need to
blood from
check that no
you.
matter what.
Yeah, I can take a drop of blood from you and see if you've got diabetes.
Mhm.
So that's what we're trying to do. We're trying to build up to that. And so the idea is to take this TB elimination strategy and make it into a broader health delivery
Mhm.
platform that's doing TB elimination, but maybe the elimination or prevention of bad outcomes from a bunch of other diseases.
Yeah. I have two more questions. One is just
Sure.
building on that one, and it came in from the chat, which is there an influence of or a problem with general medical mistrust in these communities that is also a barrier, or are you finding that no, we desperately need this help and we're ready to sign on? Like, are you getting any issues with medical mistrust or stigma in some of these high prevalence TB countries?
So,
That
when I first was working with PIH in Lesotho, and we were treating HIV in a place that just had a lot of people dying from HIV and TB. TB is the biggest killer of people with HIV.
mm,
And at first we when we opened one of the clinics, we refurbished it and we opened it with our Lesotho colleagues, and very few people came. But then as word got around that if you took these medicines, you didn't die from HIV, we'd have a lineup of people waiting.
yeah,
And the same is true from TB. Initially, people are like, I don't need to do it. But when they don't get TB and their families don't get sick, they're like, oh, yeah, I want to get TB treatment.
yeah.
And so, my feeling is that even diseases that are stigmatized, if you can get a treatment for it, it becomes unstigmatized. And that's what's happened to HIV in North America. Nobody wants to get it, but if they get it, it's not like what it was in the 1980s and 90s where it was the end of the world because you're going to die. Now there's a treatment, right?
Right.
And so that's what I think needs to happen with TB. But until you bring down rates markedly, or communities start seeing that if I go to the doctor and they tell me to take this, my kid doesn't get it, I don't get it, my grandmother doesn't get it. Once you see that change, people switch because people move towards efficacy.
Mhm.
In North America, is anyone scared of getting polio? No. We have sewage systems, we have vaccines and things like that. Is anyone scared of their kid dying of diarrhea? No. You go to your doctor and you take a pill or two and you're cured. So those deaths become very rare, right?
Mhm.
And so there's no stigma in getting diarrhea. If you're a kid, you just go, your mom or
Yeah.
dad takes you to the doctor and you get treatment. So that's what needs to happen with this, and that will only happen as we start treating people and they get better and you bring down rates. I will tell you, I think Paul Farmer used to say this. There's maybe a small percentage of people that are like, I still don't want the medicine. But 99.5% or 99.9% of the people, if you say this is going to stop your kids from getting sick and your family from getting sick, they want the treatment. And that's been our experience seeing families in Lesotho, seeing families in Russia, seeing families in Peru, seeing families in Haiti, and now seeing families in the Philippines. They want the treatment.
Yeah. Yeah. So it's another long game, I guess, in pushing back against the stigma.
And remember, they've been going to health systems that have not had the medicines to treat them properly. So you spend a day's wage going to the doctor, you don't get the right treatment, and you die. So
Mm.
at some point, people are like, why am I doing this? It's not working. When it works, people want to do it. Because if
Mhm.
you say, is it worth a day's wage to not let my child die? The answer is yes, right? And people do that. We're trying to even bypass the whole day's wage thing
Yeah.
by moving care to the communities where people live and work.
Mhm.
So I think that as you try to improve these care delivery systems and the care that you deliver, both,
Mhm.
you actually are going to have better outcomes. Now, get this. If you're in a household and you have TB, you get cured. And then 3 months later, your kid gets it. And 6 months later, your husband gets it. That's not a very faith inspiring thing.
No.
But if you come in and somebody says, you know what? Your mother, your brother and your sister and your mother and everyone's also being exposed. We don't want any of you to get sick. If you take this medicine at the same time as the sick person takes their medicine, it's going to reduce your chances of getting sick markedly. And we're also going to give your whole household food to help you take these pills and stuff for the next, 6 months. Well, I
Right.
think that's kind of a faith inspiring thing because you're going to have very few people getting sick, with the food plus the medicines.
Mhm.
You're going to actually create a much better outcome for a number of diseases. And we know it
Right.
reduces all cause mortality. So it changes your trajectory of your family. That inspires faith in the medical system.
Mhm.
If you get an x-ray and you don't have TB, but they find your single lesion lung cancer and you actually can get that removed and you don't die, that inspires faith in the lung system, in the health system. So I think that there's a whole bunch of things that you need to turn around. You can't just expect people to have faith in what was not a system able to deliver. But if you create a system that's able to deliver, it inspires faith.
Right. Yeah. That is great. All right. I'm going to ask our last question because I know we're at time. And this is one that we like to ask all of our guests because we at TB Fighters here are very big on the concept of hope. And so, what are some things that are giving you hope when everything is really terrible and really hard in global health right now? Like, what are the things that are keeping you going? And where's some of that positivity and improvement we can look for?
Well, after I showed you those graphs of where rates of TB dropped wherever you do this right. And so, I don't know, maybe this isn't super scientific, but if it doesn't drop, my question is going to be, what aren't you doing right? Let's figure it out and let's work together to make it happen. So that's given me hope that we've seen it happen, and we saw it happen in Tomsk, and we saw it happen in that other place, Voronezh, whose name I didn't tell you. We saw it happen in Singapore. We saw it happen in Alaska, and there's a whole bunch of examples that happened in Japan, and it happened in Tunisia, and you could go on and on, right? So where it's happened, and it's happened all over the Western world. So we know it can be done. That gives me hope. The second thing is that I think that when you do what we're trying to do in the Philippines, where you do what we're calling technical accompaniment, you're not just flying in and saying, "Oh yeah, your system sucks. Here's a report. We'll see you later." What we're doing, and again, thanks to John and thanks to the way the Philippines government is working on this, what we're doing is we're saying, okay, you've got these challenges. We're going to work side by side with you to solve it. I think the model of technical accompaniment gives me hope because it gives the other side hope. Literally, I'm not kidding. When we started talking about this, people were like, could we really bring down rates in the Philippines? To now, the local doctors are like, we're bringing down rates, doing search, treat, and prevent. So that the power of solidarity and the power of vision using something that you think will work is incredible to me, because I know that alone changes the world, because you've got a group of people who've been working really hard and not seeing rates change now believing that they've got the ring that's going to give them they can give them what they need, and that ring is the search, treat, and prevent. So that totally gives me hope. And then also, USAID is not there in the Philippines right now. I mean, the US government is giving some money, but I was really heartened when the Philippines government said, no, we want to see this happen because we believe in this. And I was heartened when in India we started talking about doing this and giving cash transfers and all this. And everyone initially, when we were talking about this in 2014, 2015, said, that's crazy. We're not going to be able to do this in India. Now, search, treat, prevent, and the prevent part is part of the Indian national policy. They're giving cash transfers to sick people, right? And so you're like, this is happening in a country with 1.5 billion people, with the largest TB burden in the world. Well, wow. So that means this idea of what needs to be done can be transformative and can change things. That gives me hope. I'm not saying we don't have miles to go before we sleep. We have a lot to do. But there are these things where you see that you can change the status quo, and you can actually hopefully bring down TB rates. And the last thing is, people say, oh yeah, you guys do this in small communities. It can't happen in an Asian megacity. I showed you those data from Pakistan. Pakistan's 22 million. That city in Pakistan, Karachi, where this was done, it's 22 million people. And this was done in an area of 2 million people that was not a closed system. And you saw rates drop 20 or 30%. And you saw the same thing happen in the favelas of Rio de Janeiro, that other graph. Yeah. That gives me hope. So I don't look at TB. I mean, of course, I'm disheartened that it's a long game. It's not a one-year project. That, of course, makes it harder. But the fact that it's possible and achievable, and that using this platform, you can link it to solving a bunch of other disease problems as well, that gives me hope that we're going to be transformative in the world.
Yeah. The knowing that if we can get people to do it, it will work is a huge piece of it. Like, we know how to solve the problem. We just have to get everybody to let us do it. And that, it's not solving something that's not solvable. Yeah, that is a good thing to hold on to. So thank you so much for being so generous with your time and coming to talk to us. It has been great to have you. I have a couple of announcements that I've got to speed through really quickly before we can let you go.
Before you do that, can I just say something? I'm so proud of the nerd fighters, just seeing what's happened, people talking to congressmen, talking to senators. I just think it's been such an important thing, because the US is one of the biggest drivers of this. Like, when you think about hope in the world, the US kind of pushing the narrative that you can fix these things is one of the drivers of hope. So
Yeah.
I just wanted to say that before.
Now, if you want to actually hear something incredible, we're going to have well over 200 people and probably more than 200 congressional meetings on March 3rd of this year in DC.
Amazing.
And a lot of that is nerd fighters just coming down and being willing to put in. And that's what my first announcement is about, actually.
Oh,
so it's a perfect
sorry to steal your
segue. So
thunder.
thank
That's
you for
great.
setting me up so well. And if you are watching this live, not on the recording, and you are attending TB Hill Day, we have one of our mandatory trainings happening this week. So you're going to find the email details for that in your email. And if you're just a nerd, which if you're watching this, you probably are, we would love to see you at our TB Breakthroughs and Tools training on Thursday, February 19th at 8 p.m. Eastern, right here on YouTube. That's going to be hosted by our friends at TAG TB Alliance and IAVI. There's also going to be a TB 101 training brought to us by NTCA and We Are TB in early February. There's going to be details to follow on that, so keep an eye on emails. Our TB Readers Book Club will be starting Stigmatized, a Mongolian Girl's Journey from Stigma to Illness and Stigma and Illness to Empowerment on February 1st. And you can find details on that in the doobly-doo or on our website. And finally, if you have ever wanted TB merch, or I guess anti-TB merch, actually, we are broadly in favor of hating TB. We are launching some of that very soon with our friends at DFTBA. So once again, keep your eye on the email to find out when you can order that. If you want it in time for Hill Day, you do need to order it before Project for Awesome starts. I think that is everything. If it's not, subscribe to the newsletter and find out about all the things that I forgot. And I guess also subscribe on YouTube. I'm a streamer now. I'm supposed to say things like that. So, and to close us out, as they say in our hometown, don't forget to be awesome.